So I'm going to introduce Dr. Jeannie Youngwerth here, and we'll get her PowerPoint going as soon as we get some help. Dr. Youngwerth is an associate professor of medicine at the University of Colorado School of Medicine and director of palliative care services. With the direction of Dr. Youngwerth, the palliative care team at UCH focuses on education, research, and improving the quality of life for patients and families. This model of care is not dependent on prognosis or stage of illness. So welcome. Thank you.
Well, hello. Can everybody hear me okay? Okay. We can start. I know the slides will probably come up as we're talking. And I first wanted to thank all of you for being here and for having me here to get an opportunity to talk with you all. I really appreciate that. And I really also want to give an extra thanks to Sue and to Bella and to Dr. McGee for sharing their stories with us, which is not an easy thing to do, and it takes a lot of courage. So I wanted to give them an extra thanks. And I was asked today to talk about palliative care and how that can enhance your own health care. And we do this by putting the person first and focusing on quality of life. And we'll talk about 3 different things today. First, we're going to talk about just where palliative care fits in overall health care today. Second, we'll explore how palliative care may improve your own health care. And third, we'll talk about palliative care as well as hospice and the differences between them. So, I don't know if you have heard of Hippocrates before. Hippocrates is known to be the father of modern medicine today. And this is back in around 300 or 400 BC. Hippocrates actually started the first medical schools. And he has a lot of teachings that he had that actually held the test of time and actually still hold true today. And I wanted to read to you one of his quotes. And this is where Hippocrates really embodied what person-centered care is. And this is something that at one point in medicine we kind of strayed away from, and now we've really brought it back into the mainstream of healthcare. And he said it's more important to know what sort of person has a disease than to know what sort of disease a person has. And this really rings true when we talk about palliative care. Our focus goes beyond the illness and brings it back to who is this person behind the illness. All right, do this. There we go. So first we'll just look a little bit as where does palliative care fall in healthcare today. I was asked to give just kind of a brief overview on this. And this is a graph where on the horizontal is looking at over the decades, and the vertical is looking at how much we spend in healthcare. And these are industrialized or developed countries, and comparing them with the United States. United States you can easily pick out because we are the one that is the outlier, way on top, circled in red, where we spend sometimes double or more than double of the other industrialized countries on our health care. And one of the things, that we want to look at is, well, what are we getting out of this? And if you look at something as simple as just life expectancy from birth, we actually have the lowest life expectancy. We, again, are outliers compared to the other industrialized countries, even though we're spending at least twice as much on our health care than other countries are. So we want to see what are we getting out of this? What about our quality of life for health? And there is a survey that was done across over 135 countries in the world, both industrialized as well as non-industrialized countries. and they looked at quality of life for healthcare. These are some of the main things that were determining that, which is life expectancy, infant mortality, preventive medicine, as well as being able to get access to the healthcare that you need. And if we look at what country ranked number one across the world for healthcare, quality of life, I tried to give you guys a hint here. Which country do you think was ranked number one? In the right area. This is actually Iceland. They ranked number one. And where do you think the United States was ranked? I heard 5, I heard 13, heard a lot of laughs. Believe it or not, we're actually 39. And to give you some perspective, that's behind Cuba, that's behind Taiwan, that's behind Kuwait, and our quality of life for healthcare. So if we're looking at quality of life for health, then I think it's only fair that we also look at quality of life for death. Again, a similar study was done where they looked at countries across the world, both industrialized as well as non-industrialized. Not as many this time. There was just around 35 to 40 countries that they looked at. Now, which country do you think was ranked number one for quality of death? Oh, sorry, these were the factors that they're rated on. Okay, and I tried to give you guys a hint here. A lot of people say Ireland. I should probably change that picture because we'll just kind of expand a little bit to the UK. And then how about where do you think the United States was ranked? This is where we are ranked number 9. Probably not as bad as quality of life for health, certainly nothing to brag about. And being a physician in the United States, this is something I think is extremely humbling. We have a lot of work that we can do to improve our health care for our folks. So I think it's probably fair to say that right now, I know there's a lot of things that have been going on with reform and discussions with that. Regardless, the healthcare that we have is not optimal. And we have an extraordinary amount of spending that we really are not getting a ton out of. We don't have really high quality of life for health, nor quality of life for death. So this is where we talk about value. When people talk about value, it's trying to get as much quality as you can and without spending extraordinary amounts. So it's like if you go to buy a car. You don't want to pay, $100,000 for a car that's going to break down every week. You don't want to pay $20,000 for a car that's going to break down every week. You want to buy something that's reasonably priced, that's going to last you and be reliable, and something that you can trust. That's what we mean by value. And we want the same thing when we talk about for healthcare. So there's an agency that's called the Institute of Medicine, and they are advisors to the federal government. And many years, or actually a few years back, they were actually asked to take a look at the state of healthcare in the United States and to make a formal report, and specifically focusing on people who have serious illness. And so they made a report, they published it, and then they talked about their findings. Not surprising, what they found is that there are a lot of gaps in the healthcare for people who have serious illness. And that we've actually helped people to live longer now, but we really haven't been able to catch up in helping people to live better during that time. And that's something that we really need to, as a country, is to put attention and to focus on. So the American Cancer Society actually really embraced this, and after the Institute of Medicine came out, they started making these advertisements. Because when the Institute of Medicine gave these different recommendations, starting at the level of government, healthcare insurers, universities educating healthcare providers, and going all the way actually back to the public, and saying, you know what, you should actually be expecting and demanding healthcare that's focused on you as a person and your quality of life. And so they made these really nice adverts that really focused on not just the treatments here, but the person behind the treatment. And that is where palliative care comes in. You can't read, probably that writing is too small, but it's talking about palliative care in the fine print there. And actually, American Cancer Society's recommendations for people who have advanced cancer is that if you are not offered that by your healthcare team, then you should be asking for that. So let's talk about how can palliative care now improve your own health care. And what we found over time, there's been a lot of studies now, it's coming back to the value of health care. We know that palliative care helps to improve quality, better quality of life. You may even live longer, having your symptoms better controlled, like breathlessness, tiredness, pain, and that you have better satisfaction or are more satisfied with the care that you are receiving. And it can help those that may be helping to care for people too, in making things a bit not as difficult or as burdensome to provide that care. It can help with grief as people go through their illness, as well as when people do die. Most people in America actually prefer to die at home. Most people in America do not die at home. They die in the hospital. So for those that do wish to die at home, making that actually a reality. And then what we found is that when you do bring this into people's care, it actually comes along with lower costs. And that's what we're getting at with our value. That's outside of the hospital, that's in the hospital, makes it less likely that you'll have rehospitalizations or emergency room visits. So this is where palliative care improves quality. And it was about, I guess it was 8 years ago now, there was this really important study that came out. And it was published in a journal. It's called the New England Journal of Medicine, which is considered to be the most prominent journal for healthcare. And it made it into the news and everything because this was a really kind of changing study. And it looked at people who had lung cancer, people who were first diagnosed, just diagnosed with lung cancer that had spread to other parts of the body or metastatic. And this was actually coming out of Harvard. And they split the patients into 2 different groups. One group received the care that they normally would from their cancer docs. The other group also received the care that they normally would from their cancer docs, plus they had palliative care along with it. And what they found was that the group that also received palliative care, they did much better than those that did not have that. Their quality of life was better, their symptoms were better controlled, their mood was better, they had less depression as they were going through their illness, they were more satisfied with their care, and they tended to live longer also. And by a few months, when you talk about metastatic lung cancer, a treatment that helps people to live longer by a few months is considered to be a very successful treatment. So this is not adding any extra kind of drug or anything. This is just bringing in palliative care along with folks' cancer care. So what is this palliative care thing that I'm talking about here that the Institute of Medicine is talking about, that study brought in to help improve the care for people who have metastatic lung cancer? What is this thing that helps to improve outcomes for patients and families? And if you think about it just as a kind of quick snapshot, it's about quality of life and your well-being. That is what our focus is on. And this is alongside the care that you normally receive from your doctors and your healthcare providers. And what we do is we give people the opportunity to talk about the things that matter most to them and make sure we are doing our best to incorporate that into your care. I'll also give you guys a formal definition. And the formal definition of palliative care is it's specialized medical care for people who have serious illness. Specialized in the fact that this palliative care is a board-certified medical specialty, just like lung doctors with pulmonary or oncologists may be, and it's provided by a team. We tend to go around in little groups. The team consists of 4 different types of healthcare providers: doctors, advanced practice nurses, social workers, and chaplains. That's our core team. And we are focusing on quality of life for the person who has the illness along with their loved ones. And a lot of things that we may do to be helping to improve quality of life may be around helping to control symptoms that are distressing, whether that's breathlessness or pain or tiredness, fatigue, along with the stress that comes along with a serious illness. And being there for a support for both the patient and their loved ones. It is independent of prognosis. So the criteria for palliative care of who benefits from this is having a serious illness and when it's affecting your quality of life. Remember that the Harvard study showed when a person was first diagnosed with the lung cancer has spread is when they did best bringing in palliative care. And the way that we do this is by filling in the gaps for care. Remember, the Institute of Medicine talked about there's a lot of gaps in our healthcare right now. How can we help fill in those gaps? And these are the things that we focus on, and I'll explain what some of these things mean in a moment. So if you think about, we'll just break it down. The G is for goals. Goals of care is what we call it. The A is for advanced care planning. Again, I'll talk about what this is. The P is for psychosocial spiritual support. And I don't know if Bella's still here. When Bella was talking about that mental strength that is so important, this is what we're getting at here. And then the S is for symptoms that are impacting your quality of life. So goals of care is, it's really a medical term. What that means is learning what matters most for a person. We'll use the words values a lot of times. What are a person's values, those things that matter most to them? And making sure that their health care is focusing on these things. We don't want to presume as a doctor, as your healthcare provider, that we know what's important for you. We need to learn it from you because it's going to be different for every single person. So when you meet with us, what we normally do is we sit down and we hear your story. And it's not only your story about your illness, it goes beyond that. In fact, we'll talk about even before maybe you were diagnosed with your illness. Tell us about yourself. What we want to learn is who you are as a person. And as you tell us your story, you can see where your values start to come to the surface. And it starts to a lot of times become clear for yourself and for your healthcare team and for your loved ones, those things that matter most. That's what we're getting at. And we know that quality of life is going to look different for everybody. And there's so many different things that can play into what is quality of life. This is where we learn what it is for any particular person. So remember that our goal is to learn what matters most. We want to make sure that it's helping folks on a day-to-day basis. We want to make sure that it's helping you when you're actually coming down to times where, maybe you need to make some decisions about your health care. And they're not always going to be easy decisions. What we've learned is that when you focus on those things that matter most, those values, what we call goals of care, and that when we are seeing if that aligns with the next steps for medical treatment, that's when we know that we're doing the things that are going to make sense for you and to help improve your quality of life. When you look at things, everybody wants to have a nice, smooth course with their illness. And we know that in reality, it's anything but. There tends to be speed bumps in the road. There tends to be potholes. And sometimes potholes big enough of the kind that swallow cars. What we're trying to do is minimize those bumps and those potholes and to help even decrease the unknown so that you feel that you have the strength to get through things as best as you can, as well as your loved ones. So that was the G in the gaps. That was goals of care. I want to briefly talk about the A, which is advanced care planning. And advanced care planning is where you now take those things that we talked about, those things that are most important for you. We've kind of summarized it. We're doctors, so we like to talk in bullet points a lot. So we can write things down in the chart and make sure other healthcare providers know those things that are most important for you. And you now have the opportunity to talk to your family about these things, your other healthcare providers, as well as for those times when you cannot speak for yourself, which are going to happen at points during your illness. That's normal. That people are aware of those things that are most important for you. Like when Dr. McGee was on the life support machine, he wasn't able to speak for himself. We want to make sure that your voice is still heard and that your wishes are still followed. This is advanced care planning. It can be from the time when you're diagnosed with your illness all the way through to end of life. And what we do know is when people are getting closer to end of life, it is most common that people don't have the ability to speak for themselves then. And we want your voice to be heard. This is where we want to make sure that you are in control, even during these times, that your loved ones feel confident that they know the things that you've told them before. I hear it every day where people say, this is family members or loved ones. And they're like, I wish we would have talked about these things. And it causes so much stress. And when you have talked about these things, this is where that stress really starts to go down. We know looking at outcomes, families do better, less stress and anxiety and depression, and they're much more satisfied when you've had these discussions before a crisis happens. And that it is more likely that your wishes will be followed, again, if these discussions have already happened. So one thing that you can do, and I don't know if folks have this here, have folks heard of a medical durable power of attorney? We also call it an MDPOA. I will say right now it is different from a financial power of attorney. They are not the same, they don't cross over. Does anybody here have one on paper and in the hands of their doctors or healthcare providers? Excellent. Thank you for those that have those. And for those that don't, I'm very happy to help connect you to get some paperwork and some resources that we'll talk about. Colorado is a funny state. It is different from other states. Colorado and Hawaii are the only states that have a particular rule around who your voice is going to be when you can't speak for yourself. So let's say you now don't have the ability to speak for yourself. Who does it default to? Absolutely, if you have a medical power of attorney, it will default to them. What if you don't have a medical power of attorney? State, spouse, the doctor. Believe it or not, in Colorado, it's none of those. It's none of those. We are what is called an all-interested party state. That means anybody who is interested in having a say in your health care can come to the table that says, I want to be that decision maker. You don't have control anymore. It may be somebody that you would want. It may not be somebody that you would want. And what our role on the doctor side is to gather all potential interested parties and to sit down and talk through and try to help folks decide on who is going to be that spokesperson for you that is speaking for you and not for themselves. So that person is called a medical proxy. So if you do not have an MDPOA, you land in the hospital, this is what happens next when you cannot speak for yourself. So to protect yourself and your loved ones, I really encourage you, particularly important in Colorado, that you take the control and have this. And it has to be in your doctor's hands. When you're at clinic, when you're in the hospital, it has to be in their hands. If the paper's not there, unfortunately, it doesn't exist. So you have to make sure and confirm with them you have that in your electronic medical records, right? Yes. All right, we're good. And I'll tell you that sometimes this can go smoothly in that process, and sometimes not. Even loving families, when they are under stress, sometimes that brings out the worst in folks, and there can be a lot of fighting. And what that means on your end, in addition to your loved ones having more stress, is that a lot of times decisions for your health care get delayed. And then you're not receiving sometimes the health care that you need as soon as you could otherwise. Here are some resources, and I've been told that you guys have handouts, so hopefully that, oh, you do, I see them, okay. You can see the resources on there. A wonderful website, which is actually new, is called Colorado Care Planning. I highly recommend that. It goes over all different parts of advanced care planning, as well as resources, links to documents. And by the way, all this stuff is free. Getting an MDPOA is free. You know, if you write a living will, it's free. You do not need a lawyer where you're going to pay a lot of money. I recommend instead of talking to a lawyer about your wishes, you talk to your family and your healthcare team, because they are going to be the ones that need to know that information, and it doesn't cost any money. The top three in white, the Prepare for Your Care, well, actually the number 2, 3, and 4, Conversation Project, Prepare for Your Care, and Med Stanford, those are all ways to help facilitate thinking about these things as well as talking to your loved ones. Knowing that sometimes it's just really uncomfortable to talk about these things, or sometimes your family is really uncomfortable talking about these things. And to do different creative ways. The first one is a lot on paper and talking. The second one is if you like to do things on the computer or online. And the other one does, the Stanford's very creative. It has letters, it has bucket lists, it has all different ways to see what might work for you and your loved ones. And yes, the bottom one really does say getyourbleeptogether.org. That's actually just an interesting story. That one is not so much about how to have these conversations, more of talking about resources for the financial part of things as well as the medical part of things. So we got the G and we got the A for the gaps, and this is the P. And this is what Bella so nicely talked about as that mental strength. We call it the psychosocial spiritual support. And I'll tell you that if we only focus on the physical parts of your illness, we're not doing you a service in caring for you. Because illness, as you know, affects every aspect of your life. And there's just not as much stuff as far as in the research part of things. There was a study that was done on people who have COPD or chronic obstructive pulmonary disease, including emphysema, chronic bronchitis, and found that almost 15% said that, it's really a significant problem for them. That they actually feel like they're losing their dignity from their illness and the way it's affecting them. Where they can feel ashamed, maybe embarrassed or degraded. It really affects even just how you might interact with the people that you care about or your social ties. Maybe you're not going to the social things that you had been before because of now how the illness is affecting you. Or maybe even withdrawing from your family and your friends. Things change with illness, and these are the things we want to see, how is it for you, and how is it impacting you? How are you able to relate to others now? Sometimes it's really hard to relate to people when they have not gone through what you have gone through or are going through. What are those things that bring in your mental strength? If we're aware of those things that bring that strength out and from the inside, we can help lift and to bolster you as you go through your illness as well. So this is what we talk about with the psychosocial help. Then the last part of GAPS is the S, and this is symptoms. This is what a lot of times docs tend to focus on. And this is where now these are symptoms that are not getting better despite treatments directed at your illness. And this is where palliative care folks can help with that, because we're not just focusing on the illness, we're focusing on the symptom that the illness is causing and helping to treat that symptom. So again, studies looked at COPD with this. Not surprisingly, shortness of breath or breathlessness was the most common symptom. People also felt very wiped out, fatigue, weak, low muscle strength, as well as other things. Cough that was distressing, problems with sleep disturbance, feeling a low mood or depressed feelings, your appetite just not being what is there or used to, not being distressing for you, anxiety, as well as pain. And we've also looked at people who have pulmonary hypertension, which tends to not, for instance, get looked at as much on these things as far as for studies. And what they did was they looked at people with pulmonary hypertension, and they compared it to people who have cancer. And the heme, that's the CA is cancer. Heme means blood cancer like lymphoma or leukemias. The solid cancer are things like lung cancer or pancreas cancer, different kind of cancers that come from your organs inside. And what they found is that for every symptom, except for pain, where it was pretty similar, for every other symptom, pulmonary hypertension caused way worse symptoms than cancer. And cancer has been really well studied, and we know that people who have cancer have an enormous amount of symptoms. So this tells you even how much more that impact can be for people who have pulmonary hypertension. So to give you guys an example of some things that people can pull in to help with that breathlessness or shortness of breath, this might be through things as simple as just the position that you're in. Maybe that's leaning forward or sitting up, learning different kind of breathing techniques to help maximize your breathing and decrease that breathlessness, learning how to really manage your energy. What are those things? How are you going to conserve your energy during certain times? What are you going to focus your energy on during other times? And really making a good plan with that, particularly when you have things that are really important for you that are coming up that you want to make sure you've got the most energy to get through. Maybe it's relaxation techniques, or a fan blowing in your face, wind blowing in your face. Acupuncture has been shown to help. You guys are more than familiar with oxygen and the benefits that can come with that. And pulmonary rehab, and I've been told that there's probably quite a few folks that either are currently enrolled in pulmonary rehab or have been enrolled in the past, which can have huge benefits for breathlessness. Thank you to our pulmonary rehab team and folks that are able to participate in that also. There's different kind of ways that you can deliver oxygen. One of them we call non-invasive pressure ventilation. That's where you're not on a ventilator machine. It is a machine that delivers oxygen that you can actually receive at home and just more intensity in that delivery of it. Opioids are a medication that have been shown to be very effective in relieving breathlessness, as well as having, if you have, for instance, COPD where you have flares, or we call them exacerbations, those times where your disease gets worse, a lot of times it might be brought around by an infection, having a plan for that. Having a plan that you can start immediately, that you and your healthcare team are aware of, and that can help prevent you from getting hospitalized from one of those flares. I'll briefly talk about benefits from pulmonary rehab, and this is just some of them. There are immense benefits from pulmonary rehab. It can give people the ability to get around better, to be able to walk farther, to be able to do things more that you want to do. We call that your exercise capacity. We know that it improves your quality of life and your well-being, as well as increases how long that you may be living also. It helps with your symptoms, those ones of breathlessness or shortness of breath, anxiety, depressions. It makes it less likely that you'll have to be hospitalized because of your illness as well. And even when you're done with pulmonary rehab, if you continue the techniques that you learn there, those benefits can be long-lasting too. So when do we add in palliative care now? And specifically for people who have respiratory illnesses. So the American Thoracic Society made a statement about this and said palliative care should begin when a person who has respiratory illnesses starts to become symptomatic. What that means is when you're starting to have symptoms, whether it's breathlessness or other things, that are really having an impact on your life, and they're starting to affect things. That is a great trigger for bringing in the palliative care folks on top of your usual healthcare team. So when you think about palliative care, think of it with your usual healthcare team. I always say that it goes hand in hand. There's going to be some times where your usual, say your pulmonologist or other providers, are maybe a bit more emphasized during your care. Palliative care is still always there, but they might be a little bit more in the background. And then there's other times where palliative care may be more in the front ground and the pulmonologist may be more in the background. That's going to tend to go and fluctuate over time. When you're first diagnosed with your illness, a lot of times palliative care is there, just more in the background. As your illness gets worse over time, you probably will have the palliative care folks more up front and center with you through that time. And this is showing just what to expect a lot of times. And this is a generalization. Doesn't mean that every single person has this. When we talk about illnesses, what do we expect? What does that look like? We'll talk about respiratory illnesses last. We'll talk about what's most predictable first. Most cancers tend to be pretty predictable in what we expect over time. So the horizontal line, which goes across here, is going over time from diagnosis all the way through end of life. And on the vertical axis, functional status means basically how well you'll be able to get around, how well you can do the things you want to do, care for yourself, those types of things. And when people have cancer, it's not uncommon that they are first diagnosed when they still have a good ability to do the things that they want to do. As they go through their treatments, they tend to do okay, just very slowly kind of decreasing in their ability to do things that they want. And then at some point, when the treatments are not changing the cancer anymore and the cancer is getting stronger, that's a lot of times where people start getting hospitalized repeatedly. It may be from infections. It may be from different complications, blood clots, those types of things that just happen one after the other. And the way a person can get around just starts to plummet. And often people can die within weeks or even months after that time. When you look at the yellow line, which is dementia or frailty, a lot of times when people are diagnosed with dementia, they've already lost a lot of ability to be able to care for themselves. And they tend to have a much more just kind of gradual decline over time. Years and sometimes even over a decade. And this is where now you get to the point a lot where you really need someone to help care for you for even things like helping you to feed yourself or to bathe yourself. Or maybe now you're not able to walk anymore, you may be bedbound. At some point, it may be from infection or other things, people will then die. And a lot of times you're already at a low state for function at that time. For chronic respiratory illnesses, again, this is a generalization, it doesn't include everything, but people a lot of times will go through flares, especially prominent with things, illnesses like COPD. You go through those flares are the times where you a lot of times end up getting hospitalized because of that to get through it. When you have those hospitalizations, you really tend to get really weak from that quite quickly. And then as you recover, you tend to bounce back up. And many times it's not back to your baseline. You've taken a step back. And the more that you start having these flares or exacerbations, the weaker over time that you tend to get. What this graph doesn't show are when you have those blips or those flares, the more that you have over time, the weaker that you get, and then more commonly that you'll have more flares. A lot of the times when your disease gets more advanced, though anytime you have one of those flares, you're at high risk of dying. And you may hear that from your healthcare team. A lot of times it's hard to predict which one. So when one does end in death, a lot of times it can seem quite sudden because you weren't expecting that, and nor was your family. So that's that illness trajectory. And remember, regardless of where you are on that, what your illness is, whether it follows this or another one, your usual healthcare providers, in addition to palliative care, can make this so that you've got the best quality of life regardless. So now how can you get palliative care? And that's something that's as easy as asking your healthcare provider, your doctor. They'll get you an order, a referral, and they can get you connected. If you're having a lot of symptoms that are not being improved or other things that are going on, and you feel that we really need to focus more on your quality of life, ask for it. Remember, the Institute of Medicine, the advisors to the federal government, this is something that they want to empower you with, is to ask for it and to expect it for your care. And palliative care can come in different forms. It can be when you're hospitalized, you can see a team there. This is usually where most of palliative care teams across the United States now are located in the hospital. And probably about 3/4 of hospitals that have 50 beds or more have a palliative care team now. There may be clinics. They're not as common. You can ask your providers about that. In the Denver metro area, we fortunately have several healthcare systems and hospitals now that have outpatient clinics. And you can also get community or home-based palliative care. That's where they come to your home. And that usually looks like a nurse practitioner. And I always say if there's one that also has a social worker, those tend to be the best ones, the most robust programs, and I would recommend those. They may visit you every other week. That may be less, it may be more, depending on what's going on with you at that time. It's different from home health. Home health is where you normally will have a nurse coming out for some kind of a skilled need. You know, maybe you have a wound that needs dressing changes or something like that. Once that need is gone, the home health care nurse completes their therapy and stops seeing you. Home health can see you with palliative care can see you without it. It is not the same thing. Nurse practitioner is a nurse that has a master's level degree, much more training, and they are going to be in communication with your primary health care provider, being extra eyes for you at home, so now you have a boost in your health care to make sure that your quality of life is optimized. When you receive that kind of care, it is much less likely that you'll go into the hospital with exacerbations or flares. So now let's look at what are the differences between palliative care and hospice. There's a lot of misconceptions out there. Hopefully we can try to clarify some of these, because there are differences, and a lot of times it's just understanding some of the words and the terms around here. So when you think of palliative care, remember that what the Harvard study was when a person got diagnosed. It can be all throughout a serious illness, all the way through end of life. That is palliative care. It can be any time within there when palliative care can be involved in your care. When you're talking specifically about end of life, that may be within months or even the last year of your life. That is where hospice is focused at. Their specialty specifically is around end-of-life care. And hospice is different because it's actually a model of delivery of receiving end-of-life care. Hospice is actually overseen and regulated by Medicare. Palliative care is a medical specialty, two very different things. So since Medicare tends to make all the rules and regulations and all the things around hospice, things are much more specific around there. So it's around that delivery of care, and we'll talk about what that looks like, as well as the philosophy around your care during that time. It does depend on prognosis. The prognosis is defined by Medicare. Medicare defines it as, we anticipate that you have a 6 months or less prognosis. We can be wrong. We're wrong all the time. We know that. Medicare is okay with that. But to the best of our ability, based on your illness, and what we expect in the course of your illness, we think that there may be 6 months or less. I'll tell you truthfully, if the doctors think you have a year or less, that's where you're probably right. So this is where now we know that your therapies directed at your illness are not helping you to live longer or to live better. And now we want to shift gears and really focus back at improving your quality of life. And this may be no matter how much time that you have to live, we're going to focus on that quality and make sure that your symptoms are controlled with comfort as a focus. Knowing that we can't fix what's going on with your body, we can do things to help you live the best that you can, regardless. So hospice is a different kind of team. Again, it's regulated by Medicare and the way that they define things. It is the most health care you can receive out of the hospital, and it's brought to where you are. Their focus is on bringing it to you. And so that's normally to your home. The team is normally overseen by a physician. There's a nurse that you have on your team that maybe sees you a couple times a week. It may be less, it may be more, depending on how things are going. Same with a nurse's assistant, making sure that you're well cared for and clean. You have access to social worker, spiritual support, all different kind of counselors, including grief counselors, financial counselors, etc. This is for you as well as your loved ones. They count your loved ones as part of you and the things that are important for you. So there's extra support that goes out to all of that. They are experts in symptom control when folks are closer to end of life. And they have a very comprehensive care of what gets included, of what they cover, so that it's not any cost to the person. Again, it's all kind of regulated by Medicare. So that whole team is covered. Medications that are for your symptoms are covered. Extra equipment that you might need at home. Maybe you need a hospital bed. Maybe you need a wheelchair. Maybe a shower chair. These things are all covered at no cost for you. And the other thing that I think is really different, there's nothing else like this in our healthcare right now, is you've got a 24/7 safety net. So when things tend to go bad and you're not feeling well, for some reason it happens to be at nighttime or on the weekends. This is something that's out of office hours. So instead of having to call 911 or go to the hospital, you call the hospice team, you talk to the nurse, and they will come out to you. They become your 911. Remember, they bring care to you and to get you feeling better. So this is where the focus is on keeping you out of the hospital. So they don't cover hospitalizations. Their goal is to keep you where you want to be with your loved ones, whether that's home or somewhere else, they bring the care to you. The thing that they don't provide, which is a big misconception, is a caregiver. They don't bring a caregiver into your home to be there with you 24 hours a day. They're available to come out when you need them. When they do their visits, it might be an hour or two, but they don't stay there all day and all night. They do teach your loved ones to help care for you in addition to them. They don't pay for where you live, and that includes a nursing home. And other illnesses that are not related. Let's say that you have maybe diabetes or hypertension. You don't have to stop those therapies. Even though hospice doesn't cover those things for the financial part, your other insurance will back up and cover those things normally. So let's say that you have Medicare. Medicare will cover that through a different route so that you can continue those things as you normally would. So to give you a review, remember it's those gaps in care. We don't have a high value in our healthcare right now. We're trying to improve that and really getting back to focusing on the person and their quality. Those gaps in care for people who have serious illness from the time of their diagnosis can be filled in with hospice through the course of their illness. When you are talking about end of life, that's the time where hospice can bring that in for you. This website's a great website for a resource. It's called getpalliativecare.org. I highly recommend that. Very reliable source. And just some take-home points to summarize for today is that palliative care improves the value of your health care. It improves the outcomes for the person with their illness as well as their loved ones, and it helps to improve your well-being and your quality of life.
Are there any questions for Dr. Youngwerth?
So I was listening to what you said about the medical durable power of attorney. I know Colorado has a lot of military here. So my question is basically, does a military person living in Colorado, does that, if they don't have, like, does that fall under Colorado, their home state, or is there a government special thing?
So the question is around, what about for folks that are military? And that's a great question, because there's always going to be exceptions to things. So if they are active military, then they are considered to be part of the federal government. When you are part of the federal government, things for the state do not apply. So there is where you have hierarchy. We normally recommend, so if you, for instance, get your care with the VA, they have specific forms for you to fill out, and it is different also if you don't have a decision maker where it now becomes on a hierarchy. So that is an exception because that now falls back to the federal government.
And if a dependent spouse who is a Colorado resident, would they fall under the federal government if they're married to active duty?
So does the dependent spouse fall to the federal government? Great question. I don't know that I'm going to give you the right answer. I'd have to look into that and get back to you. I don't think so, but I'm not sure.
Okay, thank you.
Thank you very much.